Good evening, everyone. Thank you for joining us for the IDF Forum, Be Your Own Healthcare Advocate. On behalf of the Immune Deficiency Foundation, welcome. Whether this is your first time joining us or whether you've joined us before, we're honored to have you with us tonight. I'm Kathy Antela, Vice President of Education, and I will be your host tonight. Now, before we begin, a quick disclaimer that the information presented during this event is not medical advice, nor is it intended to be a substitute for medical advice. And it is always important to seek the advice of a physician or other qualified healthcare provider with questions concerning a medical condition. The IDF's mission is improving the diagnosis, treatment, and quality of life of people affected by primary immunodeficiency through fostering a community empowered by advocacy, education, and research. This means that we are committed to serving you and providing you with the tools and resources needed to be your own best advocate and a champion for the PI community. It is by offering these tools and resources that IDF can fulfill its mission of seeking to ensure that everyone understands their diagnosis, all available treatment options, and the expected standard of care, and finally, know about all the opportunities to connect and support within the PI community. IDF forums are made possible by our wonderful sponsors. It is due to their partnership and contributions that IDF is able to provide programming such as this one and the services that to everyone in the PI community. So I would like to thank our 2021 sponsors, Core Service Leaders, CSL Behring, Grifols, Takeda, Core Service Sustainers, Accredo, Horizon Therapeutics, Core Service Contributor, ADMA Biologics, Community Partner, Soleo Health, and some of our sponsors tonight will be sharing some information with us, and we won't have time for questions during their presentations. However, if you would like to follow up with any of them, their contact information will be on their slides, shared in the chat, and you will get a copy of the slides attached to that email so that you will have their contact information right at your fingertips. IDF has many upcoming events nationwide. Throughout the year, we have IDF Get Connected groups, which provide an opportunity for individuals in the PI community to meet virtually in small groups. And they are happening every single week. So if you would like to meet others with PI in a small group and discuss, share, learn, please sign up for one on our calendar of events. Coming up in April, we have more forums. We have 3 forums like this. One is antibody deficiency. What does that mean? One is managing recurrent infections, and the other one is PI. Why is it vital to be monitored? Then we have a forum for teens, and it will be career night. And those attendees there will get to meet grown-up people with PI that are out in the world of work and living a great life. So teens, parents, tell your teens to join that one. And then there will be a SCID Compass Summit at the end of April for a couple days. So if you have a family member with SCID or you have SCID, we'd love to see you participate in that event. So at this time, I would like to introduce my colleague, Angela, who is going to invite you to a special upcoming event.
Thanks, Kathy. So I am super excited to share that IDF is having its first ever zebra paint night this in about 2 weeks on Wednesday, April 7th at 7 p.m. It's an event you don't want to miss. I've spent all day, and even after this forum, I'll spend all night getting supplies together to ship out. So you definitely want to join. We're going to be painting a nice little zebra. And it doesn't matter if you're like, I'm not a good artist. You know, every zebra in the herd is different. So it will look fabulous, I promise you. So to sign up, just go to primaryimmune.org/events, and you can find this this fun event. And I look forward to seeing you all again. It's Wednesday, April 7th, and it is virtual, so anyone can join. Thank you so much. Kathy?
Thank you, Angela. So for now, I would like to turn things over to our sponsor, CSL Behring, and introduce Lauren Hecht. Lauren, please unmute yourself and take it away.
Okay, I think I successfully unmuted myself. So thank you, Kathy, and thank you to the IDF for allowing us to have this opportunity to sponsor the forum this evening and to give some information to all of the participants. CSL Behring is the manufacturer of Privigen, which is IVIG, and then Hizentra, which is the subcutaneous IG option for patients with primary immunodeficiency. A couple things that I'd like to highlight in this brief time. And I also want to let you know that the website and the link to the information will be provided in the chat. So if there is something that you have additional questions about, whether it's hizentra.com or the link provided, there is a wealth of additional resources. I want to draw your attention to the slide on the screen. And these are some of the things that are available to all patients and all caregivers through our hub, which we title IGIQ. So you can see some of them, such as our Premier Start. If you're someone that's thinking about utilizing subcutaneous therapy, that would be an opportunity to have a 1-month supply, including nursing, of the Hizentra product to see if it's something that is a right fit for you and your treatment, if you and your provider decides that. IGIQ also provides opportunities for questions regarding insurance coverage, reimbursement. We offer copay assistance, assistance towards the deductible, which I know for all of us at the beginning of the year can be very overwhelming. And then we also have programs that if you have a lapse or a gap in insurance, we can help you to continue to receive product during that time. And then our voice-to-voice advocates, whether you are a patient or a caregiver, if you would like to speak to another patient or a caregiver, not to get medical advice, but just to, discuss treatment and discuss how Hizentra fits into your daily living, that's an opportunity to talk one-on-one with another patient or another caregiver about the day-to-day utilization of the therapy. Finally, something that I'd like to bring up is that Hizentra is the first and only subcutaneous option available in pre-filled syringes. So this is something that we had been asked for a long time, whether it was patients that were having a difficult time physically drawing the medication out of the vacuum seal vials, or caregivers that just were getting overwhelmed with the number of steps. So the pre-filled syringes may be a simpler and more convenient option for both patients and caregivers. And the link that you see on your screen, if you take a second after the presentation, it will walk you through step by step the process of utilizing the pre-filled syringes. So if you are using vials right now, you'll be able to see some of the differences that make it a little bit easier, more convenient, and eliminate some of those steps. So I want to thank again the IDF and Kathy for this opportunity, and direct everybody to the IDF link as well as the Hizentra and the personalized dosing link to get additional information. And Kristin, I want to say that I'm really looking forward to your presentation this evening about advocacy, and that is right in line with CSL's mission with the Voice to Voice program as well. So thank you so much, and I hope everyone enjoys the program this evening.
Thank you, Lauren. Next, I would like to invite Maria and Lorraine from Grifols for a word from our sponsor.
Hi, everyone. Good evening. My name is Maria Cascio, and I'm with Grifols. I'm also joined by Lorraine Ozerovich. She's a clinical nurse educator with Grifols. And really, we just first want to say thank you, Kathy, and thank you, IDF, for allowing us this opportunity to speak to the IDF community. Just a little bit about Grifols. We are a global company. We're committed to enhancing the health and well-being of people around the world. And we manufacture immune globulin products for the treatment of PI. Those include Deficiency, IVIG, as well as Xembify, which is a 20% subcutaneous immune globulin. So for many years, Grifols has been strongly committed to supporting the IDF community. And we understand that part of being your own healthcare advocate is arming yourself with information about PI, about your current treatment and about treatment options that are available to you. Such as if your current therapy is not well tolerated, or you're experiencing bothersome side effects, or if it's just not working as well as you would hope, then we really advocate, and as I know you'll learn this evening, to talk with your healthcare provider and be that advocate for yourself. Of course, it's also important to know what resources are available to you. You should see a slide that has the Xembify connections and Deficiency connections information. But there's also our websites, our product websites that have a patient focused content. And this offers information specifically targeted to you and meeting your needs. So please take a look at Xembify.com and Deficiency.com. We also have those connections programs that I just mentioned. These programs offer additional support to you. And it's one phone call away, a way to get information about insurance and kind of gauge information about our products, as well as copay assistance, which is so important to affording therapy and maintaining therapy and staying on therapy to keep you as well as possible. For instance, with Xembify, we now offer up to $10,000 per calendar year to support your financial obligations with your insurance companies to meet the requirements to afford that therapy. This is each calendar year. So in essence, this could be as little as $0 out of pocket for Xembify 20% immune globulin treatment. So again, knowledge is power, and resources such as these help to arm you with the needed information to be your own best healthcare advocate. And I encourage you to really break out of any shell that you might be in to do so for yourself and or your family. And again, thank you, Kathy, and thank you, IDF, for giving us this opportunity. So I hope everyone has a great evening and enjoys the meeting. Take care.
Thank you, Maria and Lorraine, for being here. And now I would like to invite Sean McCabe and Dana Flathammer from Takeda for a word from our sponsor.
Hi, Kathy. And actually, I'm going to be joined by Nicole today. Sean is actually, I think, visiting with his parents for the first time in a year. So happy moment for him. Hi, everyone. Dana Flathammer. I am lucky enough to be the director of IG Community Support at Takeda. Now, Takeda might not be a name that's familiar to you. You might be more familiar with our Baxter name back in the day. We spun off to Baxalta, became Shire, and have now landed at this beautiful home of Takeda. Takeda has a very long history of putting the people that we serve at front and center. This aligns very, very closely with our MyIG Source program. And I know that you guys know a lot about products. We're not going to talk about products today. What I really want to talk about is support and the idea of education and support, and learning about advocacy should be regardless of the treatment that you're on. So first we have Nicole introduce herself real quick. Nicole, do you want to take a minute and introduce yourself?
Hi, everyone. Good evening. My name is Nicole, and I'm an advocate with MyIG Source. Really, my job as an advocate is to make someone else's journey one step easier than my own. As somebody that is living with PI, we have all had different experiences, and we are here to help support, guide, educate, and make your journey the best one that it can be. Back to you, Dana.
Thanks, Nicole. So like Nicole, I actually am a mom of 4 children living with PI, so I'm a member of this community. And this program, MyIG Source, is this super unique program that is built by us for us, and it is regardless of treatment. So what do I mean by that? We are an unbranded education program. We're not here to talk to you about an IG product. We're not here to tell you how to switch or if you should switch or anything like that. What we're really here to do is say, hey, Having lived with this, there can be some serious bumps in the road. And the goal is to make sure that those are just bumps and not roadblocks. And there is tremendous value in peer-to-peer support. So my IG source is here for everybody, regardless of the treatment that they're on. We have phenomenal education programs. I'm excited, Kristin, to hear you speaking today, in part because this is something we're so passionate about. We actually have a program called Be Your Own Advocate. So I love this. We actually have a wellness calendar. And the wellness calendar is basically a way for you to track your health and then tally it up at the end of, like, say you're going to go see your doctor after 3 months or 6 months, or the nurse practitioner that treats your case. It's a way for you to tally up the data that helps drive decisions. So this can be something like, how many infections have you had? How many days of on antibiotics? We send this at no charge. We have a ton of educational resources. We just introduced new one-pagers, which is all about building that relationship with your healthcare provider, which we can actually email out to you. We'd love for you to call us at My IG Source. The telephone number is up there. It's that 855-250-5111. I know they're going to put this in the chat as well. And you can call and enroll that way. We'll get you on anything that you'd like to have us send, or you can just go online at myigsource.com. It'll take about a day or two, but then we'll call you from an 855 number and connect you with an advocate who has an experience that's like yours. So we don't have an ego on this program. If I'm not the right advocate for you, ask for somebody else. That's the goal, is that you get your needs met and that you have somebody that can walk this walk with you, because nobody should have to do it alone. Kathy, I'll send it back to you. Kristin, thank you for donating your time and being here to help all of us in the community continue to advocate for ourselves. I think it's so valuable. Kathy, to you, thank you.
Thank you, Dana, and thank you, Nicole. Okay, so the moment we have been waiting for has arrived, and I would like to introduce our presenter. During Ms. Epland's talk, you are welcome to submit questions about this evening's topic and to send them to IDF host Kathy via chat, and I will make sure that we ask Kristin to answer as many of those as possible during the Q&A. So we would like to welcome and introduce our presenter, Ms. Kristin Epland. Ms. Epland is a graduate of the University of Minnesota School of Nursing, and she has a master's degree, and she is a family nurse practitioner. She treats patients of all ages at Midwest Immunology Clinic and Infusion Associates in Plymouth, Minnesota. Ms. Epland is also a member of the IDF Nurse Advisory Committee. So please join me in welcoming Ms. Epland as she presents Be Your Own Healthcare Advocate.
Well, hello, everybody. I'm Kris Epland. I'm a nurse practitioner from Midwest Immunology Clinic and our new moniker, Infusion Associates. So I am honored to be invited to come and speak. Every time I get the ask, I try to say yes. Kathy knows that. She's got me wrapped around her finger. I have given various versions of this talk at different IDF events, including the national conference. But I think the information is so useful that it's worth bringing this out of retirement to sort of reframe it in our environment that we're in today. So I'm going to go through it. And also, I should tell you, she allotted a half an hour for me to do this talk. And this girl has never done anything in a half an hour. So I am going to move it along as I go. And if you guys come up with questions as we chat or something specific, go ahead and put it in the chat. Kathy is going to be doing a triage of that, so we have time to get to everything that we can, but we may not get to every question or specific patient focus. So we'll have to navigate that if we have a lot that don't get answered. We maybe have to do something after the fact. So you'll also know that I like to have a theme. And so we are talking today about your team. So our theme is team. And we're going to talk about how to advocate for yourself with your team and how to make your team. So the first questions that we have to ask ourselves is, who is on our team? And we're going to talk about as much of this as we can today. So first and foremost, our team is made up of our healthcare providers, whether that is our specialist who did the diagnosing and is prescribing the treatment. That's kind of a slam dunk. But primary care plays a primary role in taking care of you. And so it's very important to not ignore that. And we're going to talk specifically about that today. Nurses are a very important part of success in implementing treatment, in not necessarily designing the treatment plan, but certainly implementing that treatment plan. Your insurance company is a necessary evil. So my suggestion, and we'll talk about it, is really play nice. And there's some suggestions on how to play nice with your insurance company as we go here. Pharmacists are the often forgotten contributors to your team, and learning who your pharmacist is and accessing that brain is a real important part of being an advocate in your care. Therapists such as speech therapists, physical therapists, occupational therapists, mental health counselors, career counselors, school counselors, all of these people play a role. Support staff at your healthcare provider office, those who take your triage calls may not be nurses, but they are an important part of connecting you with your advocates. Social workers, and then last but most definitely not least, your family and friends. So here we're going to start here. Scrubs, right? Old reference, but real funny show. Okay, keep going. Here's my theme. You'll catch on here. In an ideal world, all healthcare providers would be patient, understanding, have unlimited time to answer your questions, know exactly how to explain things in terms that you understand, and be able to fix all your healthcare problems in one visit, like Doc Baker. But the reality of this is actually that it's a two-sided story. You can't rely on a single team member to meet all of your healthcare needs. You just can't. You are the quarterback of your team. And so bringing in the necessary resources to answer those questions is on you. And this is what this talk is about. How can you be the best quarterback for your Minnesota Vikings? Oh, wait, that might have just been a very, very local reference. So navigating your healthcare requires that you be fully participating. You are not an innocent bystander in this. You are the quarterback. And good communication is the way that this first advocating step starts. Look at Doogie Howser. Can you believe that kid? Look how little he is. Here's some things to think about. Starting from the beginning, what kind of communicator are you? Are you Morse code or are you a bullhorn? Are you a communicator who works well with the written word, or are you somebody who is a more digital communicator? What kind of communications work well for you, and how do you receive communication? What kind of a relationship do you want with your care providers? Once you figured this out for yourself, you'll be a better communicator, and you can let your care team know how you want to be communicated with. So interestingly, this is a nice place to kind of work in. As of April of 2021, all healthcare providers are going to be mandated by CMS to have an online communication system in place. So some sort of an online portal for you to gain access to your medical record. A lot of people, and I know this because I own a portal, right? I actually have to give a portal to my patients. Some of them don't want it. Some of them are like, so many logins, so many passwords. I can't do another portal. The fact of the matter is, you don't have to, but you need to let your healthcare provider know that you can't or that you won't, so that you can have workarounds for communication. So here are some ways to communicate and how to navigate that. So if you are one who likes to communicate in writing, you have the right to ask that copies of your clinical notes be sent to you. You have the right to ask that copies of your clinical notes be sent to your consultants, right? So, hey, I have an ENT appointment coming up next week. Can you please send my last visit note to Dr. Smith, an ENT? That's where the support staff comes in, right? Like, so as the provider, I may not push that button that sends that out, but once you figure out who that is, that's your call, right? Hey, Valerie, I got to go see Dr. Evan in ENT. Can you get Chris's last note out to her office? Sure. Boom, done. Ask that those copies and notes are sent repetitively. So like if I have a patient who's seeing me for a primary immunodeficiency diagnosis and they have an ongoing relationship with pulmonology, I want to know who that pulmonologist is so that every visit note can go to the pulmonologist and it doesn't end up being a circus every time you're seen at the pulmonology office to try and recoup those notes. Maybe you're the kind of person who likes to communicate in person. Like I do best face-to-face with you. So I want to get my communication done while I'm sitting in the chair. Well, remember back when we used to sit in chairs? Yes, not virtually. But when you are face-to-face with your provider, make sure you've planned ahead so that you have your communication ready to go. We're going to talk a little bit about that. Do you communicate well by phone? Usually phone communication is only acceptable after you've established a relationship with a provider. So don't think you're going to pick up the phone and call me tomorrow and say, hey, I'm Jane Doe from San Francisco and I heard you talk. I'm wondering if you can renew my amoxicillin. I mean, you're laughing right now, but that's not insane. Like that happens and it's not acceptable. Ask the rules, right? So if you're establishing care at a immunology office or an allergy office, ask the rules like, hey, thanks for seeing me today. When should I come back? When can I call you? Can I call you if I'm sick? Should I call you if I have a new development in my healthcare? When can I expect a call back? Like if I call you with an FYI, am I going to get a call back? And what are the appropriate issues for me to call about? And then, like I mentioned earlier, we are now going to be mandated to have online portals available through our electronic health records. And so understand and agree with your provider how we're going to communicate through those portals. Is it just going to be exchanging chart information, or can you shoot me a message and can I shoot you a message back? Those are all important rules to establish. So responsibilities, your care team has a responsibility in how they communicate with you. They have the responsibility to be respectful. They have the responsibility to tell you the truth. They have the responsibility to be responsive within guidelines that are well established, be accurate provider of information, and your care team has the responsibility to be a good listener. But that's not just one-sided. You have responsibilities as well. And your responsibilities, oh boy, be respectful when you communicate with me. Be truthful. When I ask you a question, give me the truth. If you don't know, say you don't know. Be responsive. You see in the theme here? Right? And so, like I said, communication is a two-way street. If you are a bad listener, then you can't expect your provider to be a good communicator and vice versa. So definitely take these into consideration when you're interviewing a new provider, and take a look at yourself. What kind of a communicator are you? And are you meeting your end of the responsibilities? As a patient, you have rights. And I want to talk about these rights as well. You have the right to have your condition and your treatment plan explained in terms that you understand. And here's where IDF comes in. Oftentimes, the Immune Deficiency Foundation can help you decode, right? And so that patient support organization exists for a very specific reason. And I would say, number one, to help you understand your condition and your treatment plan. But if you are a good communicator and a good listener, you should be able to use your diagnosing provider for this information. You have the right to a second opinion or a third opinion or a fourth opinion. You have a right within your insurance company's expectations to have that opinion. You have the right to make decisions about treatment And you have the right to refuse treatment if you choose. You have the right to have copies of your medical records, and you have the right to have copy of your lab results. You have the right to be treated courteously and with respect. And that also is a two-way street. You can't expect to be treated with courteous and respectful behavior if you can't give that to your providers as well. We know you're stressed. We know a new diagnosis is stressful when it's made, but we still need to have respectful communication within guidelines so that we can have a mutually beneficial relationship, right? And then the sixth thing I have on the list here, which is by far not the last right you have as a patient, but you have the right to privacy, right? You have the right to be seen in an environment that is private, where you can have an uninterrupted conversation. Now, in the virtual world, we understand that sometimes these visits are happening in your car or at your desk at work. Those are the kinds of things that we really say when we see somebody sitting at work. Are you at a place where you can expect patient privacy? Okay, first of all, understand your diagnosis. The first thing I want you to think about is, how are you going to ask questions? And how do you remember these things? Now, I have a lot of people who walk around with this in their hand all the time. If you have a question, you say, hey, Siri, take a note, right? Oh, listen to her. Sorry, Siri. You have the responsibility to have your questions in a way that we can get through them in a reasonable time frame. My least favorite thing is when I've spent, half an hour, 45 minutes with a patient, and I put my handle on the doorknob to leave, and they say, oh, I have one more question. That's not respectful communication. So write things down. Repeat what you have heard, right? So what you're saying to me, Chris, is that if I give myself a shot once a week, my antibody levels will come back to normal. Did I hear you right? That is a very form of active listening. And active listening makes me feel good because I feel like I've been heard, and it makes you remember things better. So be an active listener. I often encourage patients to bring a second set of ears to help you process what you've heard. Now, oftentimes that second set of ears has to be told, you're here to listen, right? So if you're bringing your sister, especially if you're bringing your oldest sister, you have to say, you're here to listen. I want you to listen. I'm asking the questions. But a second set of ears often helps you sort of decompress from the visit later. And then develop a plan for follow-up in case you have more questions. Like, Chris, you're going to walk out of here and I'm going to have a dozen more questions when I get home. How can I ask you these questions? That's it. Ask that question, get your answer, respectfully stay within the guidelines of the relationship, and we're good. We're going to be good. So can you guys see at the bottom? I think, is it partially covered up by this? Can you see who this is down here in the picture? Marcus Welby. Kathy, can you see Marcus Welby? So this is a really funny picture because they're looking at a chest x-ray, but they're looking at it upside down. So you can actually see it better when it's on the big screen, but I love, they're so intently looking at, they're such good actors. Oh my God, remember Dr. Kiley? He's so handsome. Okay. Ask for additional resources when you are at your appointment. So what I hear you saying, Chris, is that I have common variable immune deficiency syndrome. Where can I get more information on CVID? Now, not all consultants are going to have their, CVID handout right here to give you, but they should at least know where to point you. And one thing for sure, I'm going to tell you not to do, don't be Dr. Google. Don't be Dr. Google and go to a site that is not vetted. Now, I will tell you, if you go to Dr. Google and you put in common variable immune deficiency syndrome, the Immune Deficiency Foundation website is going to come up. But how do you know that that is a reputable organization to get information? You don't unless it's vetted by your prescriber. So ask for additional resources, and please, even though that guy down there surfing is real cute, don't be that guy. So you want another opinion. This guy watched ER and now he's going to watch Chicago Hope to get his second opinion. This is this is where we get into trouble. Dr. Google is oftentimes our second opinion. And I'll even go as far as saying, you know, Mayo Clinic's WebMD is also not a great place for a second opinion. You have a right to a second opinion from a board certified healthcare provider, right? So you are entitled to have your second opinion. I'll tell you who I'm going to choose, but maybe my insurance, maybe he's out of network. All right, so here's what we do for a second opinion. First of all, consider why. Why do you want a second opinion? Is it that you were unsatisfied with some initial aspect of my consultation? Was this a provider that you don't find yourself connecting with? Was this a provider that you don't think you can communicate with? That's legit, right? If this is a provider that you're going to have to deal with a health condition that is chronic and ongoing, you gotta like who you're connecting with. Did you feel like the personality of this person is going to make it hard for you to establish a therapeutic relationship? That's legit. You can seek a second opinion. Is it that you want to confirm or refute the diagnosis? Also, legitimate reason, right? So why? So I come into your office and you diagnose me with CVID or X-linked agammaglobulinemia or complement deficiency. And I don't know you. Like I found you online. Like you were on my Blue Cross Blue Shield preferred provider network. Why should I trust that you are making an informed decision with the right data? You have every right for a second opinion. And what about this treatment option you give me? You're telling me that I got to poke myself with a needle every week? Like, I'm just going to trust that I can be able to believe you? Sometimes, depending on how this whole diagnostic procedure goes, you're going to want a second opinion. And none of us in the healthcare field are offended when that happens. So if I see patient X and patient X goes on to see Dr. B, and Dr. B says to that patient, yep, that's what you got. You got CVID. You got to give yourself a shot of a sub-Q IG product every week, probably for the rest of your life. Then you at least have some vetting that the diagnosis is right. But here's the thing. Your decisions about your diagnosis and your treatment should always be made collaboratively after all of the options are understood. I don't know if you want to collaborate with this guy. I don't think I do, but he's pretty entertaining actually. But I want to make sure that we talk a little bit about medical records and how to make your second opinion visit a little bit more productive. So if you're going to get a second opinion from another doctor after an initial diagnostic workup has been done, it is crucial for the second person that you're seeing to have access to that first workup. Now, that's not to say that you're not going to get more blood drawn. That's not to say there's not more work to do, but you can't hide that first round of blood work from the second provider. That's dishonest. And if you're starting a relationship in that way, then you are disingenuous and you're not being an adequate communicator. So I think it's really important, if you're looking for collaboration, that you bring all of the first opinion information with you to the second opinion. So choices for treatment. Well, let's just say you get a diagnosis and the first provider lays out treatment for you. Here are some of the options. Are we going to do IVIG? Are we going to do subcutaneous immunoglobulin replacement therapy? Or maybe you don't need any therapy at all. Just because you have a primary immune deficiency doesn't mean you need to be on immunoglobulin therapy. And I think we get hung up. I mean, and you guys just had some mini commercials from providers of immunoglobulin therapy, but there are immune deficiencies that are not treated with immunoglobulin therapy. So sometimes no therapy is prescribed, but just a monitoring program. Okay, we're going to come back to some of that, but I want to talk about insurance, and I want to make sure that we have enough time to dive completely into insurance. But you need to understand how insurance works. So there are some basic things to understand about insurance, and then there's some basic things to learn about using your insurance. So some of the insurance things you need to know at the time of enrollment. So you need to know when you are picking your insurance plan. There are plans that are devised with in-network providers and out-of-network providers. You need to understand what that means. If say you are getting a new insurance plan and you see Dr. B, but Dr. B is not an in-network provider for your insurance plan, you may need to go to a different doctor so that you can reap the benefits of having insurance. Using an out-of-network doctor, or provider, I should say, because I'm not a doctor, an out-of-network provider could mean that your co-payments are higher, your out-of-pocket expenses are higher, your deductible is always higher when you go out of network. And so it's important that you're using an in-network provider. Sometimes if you go to an out-of-network provider and you're like, well, big deal, it's just a couple $100s for a visit, I'll pay for the out-of-network provider that I've been seeing all along. But the therapies prescribed by the out-of-network provider are also covered as out-of-network therapies. So you may be paying more for your therapies because you're choosing to stay with an out-of-network provider. The second thing to understand with insurance is that just because your provider wants you to get a specific therapy doesn't mean that your insurance company has to pay for it. I have allocated about 25% of my week, so that's almost a full day each week, to fighting with insurance companies. And when I say fighting, I don't mean like boxing gloves, but I don't mean like we're having tea together, right? Like it gets ugly. I say I want patient to have therapy X, and they say, well, she can't have therapy X until she tries therapy ABC. So sometimes your insurance company is dictating the therapies that your provider can prescribe. And I would say, this is my 19th year doing immune deficiency care. In the 19 years that I have been a prescriber of therapies, right now is as bad as it has ever been trying to get therapies approved for patients. And part of that is due to just the pure costs of plasma-based therapies, but other parts of it are due to cost savings and cost sharing that happens between insurance companies and the subscriber, which is you, the patient. Insurance companies publish their medical policies online, and I'm not sure that many people know this. So if you are a subscriber to the Mom and Pop Insurance Co. LLC, you should go to Mom and Pop Insurance Co. LLC, that doesn't exist, so don't go there, .com, and you can look up their medical policies. So you can actually enter your diagnosis and the drugs or medicines prescribed for you, and you can see how your insurance company pays for that. So there'll be things like step therapy must fail X before they can go to this, therapy that's prescribed. And sometimes those, they'll specifically say prior authorization needed for each therapy. The prior authorization that is needed for therapies falls on my shoulders. It falls on the shoulders of your healthcare provider. So this again is where communication comes in real handy. So if you come into my office and you're like transferring care to me, like I'm coming from Hershey, Pennsylvania, and I'm going to transfer my care to Plymouth, Minnesota. I'm on immunoglobulin therapy. I got a new job. I got a new insurance. This is what has to happen. Here's my insurance card. You have it in your possession and you give it to my staff. Here is all of my demographic information that is accurate. And my therapy requires a prior authorization. So those pieces of information, if you come in knowing that, give me a leg up on continuation of care. You can request an insurance handbook from any insurance company before you choose them so that you can understand a little bit more about your insurance. And you need to, like I said before, present with your insurance card. If you have a change, if you are changing jobs, sometimes just from December 31st to January 1st, one number changes in your policy, even though your job didn't change, your location didn't change, nothing changed except one number in your insurance card. And that's crucial information if you're on one of these high dollar therapies. And it's important, like, so you can't hold on to that information and say, well, I'm just going to give it to Chris at my next appointment in March. That doesn't help you between January and March if your therapies need reauthorization with a new number. And then there's the maths. So nobody really talks about how to do the math involved in insurance, but there is clearly math involved when you have open enrollment. So first of all, what's a premium? So quick insurance tutorial. Sorry for those of you who are ahead of the game, but the premium is what you pay every month just to be a subscriber to the insurance company, right? It's your membership fee. You can choose what level of premium you want to pay based on what sort of benefits you want from this club you're joining, right? So if Blue Cross Blue Shield is your health club, your membership dues are your premium. The higher premium you pay, the more benefits you get from your club. So if you pay a higher premium, you may have a lower deductible. If you pay a higher premium, you may have fewer copays. If you pay a higher premium each month, your out-of-pocket costs are likely less. Okay, let's do the inverse of that. So you can't afford to pay a high premium each month, so you choose the lower premium. When you choose the lower premium, you're really betting on not using a lot of insurance, right? Because if you choose a lower premium, then you're going to have higher out-of-pocket costs. So your deductibles are going to be higher, your co-payments are going to be higher, or maybe you have more co-pays to pay. And so you need to understand what you're willing to accept. So you basically have to do the math. If you look at 90/10 out-of-pocket costs, and you're on a high dollar therapy, when are you going to actually meet the point where your premiums are worth it versus an 80/20 policy with higher out-of-pocket costs? So I hope it's hard when I can't see anybody's faces because I don't know exactly how much of you are nodding and how much of you are scratching your head, but I hope this helps. There's a new outlier called copay assistance opportunities. And so you already heard Grifols talked about it, CSL talked about it, Takeda talks about it, but that is each manufacturer of immunoglobulin provides co-payment assistance opportunities so that you can get some relief of your out-of-pocket expenses by signing up for co-payment assistance. Now, catch, you can't be on Medicare to access a co-payment assistance program, and that's Medicare of any variety. You can't be on Medicare from disability. You can't be on Medicare senior plans. You also can't be on any federal employee plan like the military plan. So those kinds of things aren't benefited by copay assistance opportunities. And the other thing I'm going to caution you, so if you're a private insurance member and you have a large out-of-pocket or large deductible, and you are counting on manufacturer M to pay for your out-of-pocket expenses, therefore making your lower premium worth it, don't count on it. These copay assistance programs change every single year. And there's going to be a point in time where there's a breaking point that it may not be available to you. You can't count on it. So every year I have a patient who tells me, I always schedule my colonoscopy after my deductible is met, because then my colonoscopy is free. And then manufacturer M pays my deductible. Well, the fact of the matter is you can't count on that. Your co-payment assistance program may not pay your deductible until 90 days in. Now, your provider may not care. Like, I don't care if I get paid for 90 days and I'll wait for the copay assistance program to pay me, or your pharmacy will wait, but your gastroenterologist won't wait. So if you had your colonoscopy in there, you're going to have to pay that deductible. So please do not use your co-payment assistance programs as another form of insurance. They are there to assist you. Don't count on them. So do your part. how do we do our part as a patient? Well, the first thing is, you have a primary immunodeficiency, yes, but you still have a higher likelihood of dying from cardiovascular disease if you're a man than you do of your primary immunodeficiency disease, because that's the number one killer, right? You still need to take into consideration that you need to see your primary care doctor to do your cholesterol and your mammogram and your pap smear and your skin checks and all of the stuff that we need you to take care of as a regular human. Do not ignore the fact that you have all of the same healthcare concerns that a well and healthy individual has. You need to get all the recommended immunizations, especially your annual influenza vaccine. We do not recommend live viral vaccines for patients with antibody deficiency. So that's the only consideration. In adulthood, there aren't many live viral vaccines anymore. Shingles isn't live anymore. The only one I can think of is yellow fever, and that's not routine. So get your recommended immunizations. We should talk here about COVID vaccine because I think it's a really important elephant in the room. And I just got done talking to Kathy Antela about this. The COVID vaccine is accessible to patients nationwide with immune deficiency diseases. So you should be in this current phase of vaccination if you haven't already been vaccinated. I am not going to tell you that your immune deficiency clinic is recommending this for all patients. I will tell you, I am recommending this for all patients. I would say that the collaboration of colleagues through the Immune Deficiency Foundation are also recommending that patients with immune deficiency receive the COVID-19 mRNA vaccine. I know there's going to be 100 million questions about this, and we're probably not going to get to all of them. But the fact of the matter is, we think that the COVID vaccine will create not only an antibody response, but a T cell response. And even if you have antibody deficiency and you need immunoglobulin, your T cells are capable of protecting you with this vaccine. Now, we're not necessarily smart enough to measure that protection, but we don't need to. We just need you to get the vaccine. Again, I'm going to defer to your prescriber. Ask your prescriber if they're on board with it, then you need to get the vaccine, and then we assume protection. But the best news of all is that if we are all proponents of this vaccination, our plasma pool will have COVID-19 antibodies in it within 6 months. So if your donors are getting their vaccines and are, I hope in some ways incentivized to do that, if our plasma donors are getting the vaccine, the plasma that they give today will be in circulation in 6 months. And those antibodies will be passed passively to those of you who are taking either sub-Q or IV IG. So there we go. That's sort of my abbreviated COVID-19 vaccine talk. But I think the biggest thing here is, as a part of doing your part, you have to continue to be on a wellness quest, which also means diet, exercise, ideal body weight, see your eye doctor, do your hearing exams, all of that stuff. Oh, did you see this guy with he looks like he's taking a running start with his colonoscopy here. These guys, okay, part 2. Here's another part 2 of doing your part. Take all of your medications as prescribed. And if you don't take them as prescribed, why? Explain why, communicate why. Don't take over-the-counter medications without consulting your provider. For instance, if you have a rheumatologist who prescribes diclofenac for you, and you find yourself taking Advil every 6 to 8 hours for joint pain, we have a problem because they're basically the same medication, and over-the-counter is no less effective than prescription. So we need you to consult with your prescribers and be honest with your med lists, and be accurate with your med lists. You need to communicate with your provider if you can't get the medications that are prescribed. I can't even tell you how many times I have a patient who comes in and I'll say, so how are you doing on that azithromycin I prescribed for you Monday, Wednesday, and Friday 6 months ago? And they say, oh, my pharmacy would never fill that in September. And I say, This is the reason for our visit today, so that we could review how you were doing on this medication. Yeah, well, my pharmacy said my insurance didn't cover it. If that's the case, I'm gonna need some communication about this. Like if your pharmacy didn't call me, then you should be calling me. If we don't have a plan B, what are you here for? So that's a part of communication and advocacy. If you can't get your medication, I want to know about it. And then when I prescribe it, take it, right? If I say, I'm going to put you on vitamin D, and I want you to be on 50,000 units of vitamin D once a week for 6 months, and then I want to see you back. And you start the vitamin D, but it gives you a stomach ache and it makes you have diarrhea and you can't take it. So 6 months later, you show up in my office and I say, well, we're going to do your labs today and see what your vitamin D level is. And I take your vitamin D level and it's 10, it's real low. And I call you up and I say, oh, wow, I'm going to have to double your vitamin D because that 50,000 a week wasn't enough. Well, the fact of the matter was you weren't accurate for me. You didn't communicate to me. You didn't tell me that you tried to take it, but it gave you diarrhea. You didn't change it on your med list. It was still on your med list. And you let me draw your labs without telling me, oh yeah, that's right, vitamin D gave me diarrhea. That's the kind of communication that should have happened at the time the symptom happened. And that's your ability to be the advocate for yourself and for your therapy. So tell us if you can't tolerate medication. The goal, do you guys remember these guys? Kathy, do you remember these guys? Yeah, these guys might be the reason I went into nursing in the first place. The goal of all of this is to establish a therapeutic relationship, to establish a partnership where you and I, so you and your care team, can work together to optimize your health. That's the goal that you have. But here's the surprise. I have that goal as well. So my goal as a healthcare provider is to establish a partnership with you that optimizes your health, because your health is a reflection on me. And I want to be good at my job. I want to be good at caring for you. And I want to have job satisfaction that allows me to advocate for you who advocates for you. Does that make sense? I can't see you either way, so I guess I shouldn't even ask questions. So you and your provider have decided to start a specific therapy, right? Here's an example. We're going to choose immunoglobulin. So you need immunoglobulin, right? You've been through the whole diagnostic process and we've landed on you need immunoglobulin so that you can be the healthiest you that you can be. We have a couple of choices, Sally. You can be on IVIG or you can be on sub-Q IG. First, so our first decision is we're going to start sub-Q IG. So we laid out the options. You chose sub-Q IG. This is how we're going to do it. How fast do you want it to go? How many times a week do you want to do it? Do you want to do it once a week? You want to do it once every other week? Heck, you want to do it every day in a tiny little dose every day? We can make that happen. How many needles are doable for you? Do you want to put in 4 needles and get just a little bleb per site? You want to put in 2 needles and get a bigger bleb per site? Would you like to use a pump to push this in, or do you just want to push it in? We have some options, right? This is a conversation that we're having. So the benefits then, in regards to this conversation of having a therapeutic relationship, make this discussion easier. So if I know up-to-date information about you and you know up-to-date information about your diagnosis, then we can get to the decision-making. We're going to go with sub-Q IG. Participate in making decisions about your medical care. I'm asking the questions, how many needles do you want? Have an opinion, right? Participate in that medical decision. How often do you want to do your shots? And I don't care is not an answer, right? Participate, be there, be present. Manage your symptoms and get good follow-up care. That's the benefit of you and I communicating. If you're having adverse events of drugs and you don't tell me, I can't help you. Make the most of your time with me. Come with your lists, right? Write things down. Bring a second set of ears so that when we're together, we're all hearing the same thing. Reduce stress by making sure your questions are answered and your concerns are addressed. Now, granted, we may not be able to do everything in one sitting, but we can eat that elephant bite by bite. And more we see each other, the better our relationship is going to be. And all of this will make you feel more confident that you're getting the best care. So patients who hop from doctor to doctor to doctor are hopping because they are not getting the communication that they need. They are not establishing this therapeutic relationship that we're talking about. So we talked about some of this. Come in with accurate information, medications, doses, drug allergies. Keep this information with you, and consider a living will or a power of attorney that provides guidance to your care team with your wishes. That may be your husband, your spouse, your daughter, your son. It may be your next door neighbor. I don't know that that's always a great way to start a relationship. Hey, I'm your new next door neighbor. Would you like to be my power of attorney? Not a good way to start. Here are some questions that you can ask and that you can actually write down that will help with clear guidelines to make everybody's expectations clear. So when should I see my primary care provider and when should I see my immunology team? These are really important questions to ask. It's important for you to have a primary care doctor who is getting information from your consultants. And so if you go into your primary care office with concerns like, my immunoglobulin is hurting a lot when I give it on my abdomen, is your primary care going to know how to troubleshoot that? And I'm going to just make a guess and say, heck no, that's not what you take to your primary care. If you come to your immunology clinic and you say, I have an enlarged thyroid, right? I have an enlarged thyroid. Chances are your immunologist is going to say, I need you to see your primary care, right? So having clear expectations about what's your responsibility through primary care and what's the responsibility through your consultants. How will your providers communicate with each other? So if I have a patient with a primary immune deficiency and diabetes, am I going to be able to communicate with your endocrinologist? Is your endocrinologist going to communicate with me? How will we know if something goes wrong, who to call? And those are expectations that need to be discussed at your visits. When should I come back for follow-up? So a lot of immune deficiency clinics are recommending yearly follow-up for their patients. And that's great. If you're stable, Mabel, nothing going on, don't got no questions, everything's answered, and we're on the road, maybe yearly is fine. But those yearly visits can be a lot. So I often will recommend that patients, if they're on a complex medical therapy like immunoglobulin, I'll often recommend that they come every 6 months. Some of them come every 4 months, so 3 times a year. That can also be driven by you as your own advocate. If your doctor says, so Sally, I'll see you back in 12 months, you have the right to say, you know what? I just feel more comfortable if I'm making contact with you more frequently. Can I see you in 6? That's your right. When you leave a message on the triage voicemail or with the front desk, who's going to call me back, right? Are you going to call me back? Yeah, probably not. Your provider's probably not going to call you back. And don't feel put off by that. Your provider is seeing a full day of clinic and then returning phone calls, oftentimes at later in the evening. And it's sometimes better to get a call back from a medical assistant than not to get a call back at all. So establishing who's going to call me back, how are we going to communicate? And then again, the portal. Start wrapping your heads around using a portal for communication, because I can do a portal while I'm sitting here at my center island having dinner. Right, I can shoot you guys messages back. So I think portals are going to be the future of communication. And then what do I do if I really, really need you? So Kristin Epland, I am in the emergency room and they tell me that I have a pneumonia. Do I page you? Do I have the doctor page you? Do I wait till tomorrow and get you the information you need? Do I trust that I'm going to be admitted and they're going to know what to do with me? All of that stuff in case of emergency needs to be discussed. So I gave you guys a lot of stuff to work at for advocacy. We're going to do a question and answer session. And so I'd like to address some of your concerns. I know I didn't get to everything and I really tried to go fast. How'd I do?
You did amazingly wonderful.
I did all right. I did all right getting through it. So go ahead.
Thank you, Chris. Absolutely wonderful. So here we go. Thank you, Chris. You did a fantastic job. Lots of great information here for everybody. And now I would like to introduce Katie and Mark, who are from Accredo, and they're going to share some information with us.
Can you hear me?
Yes.
Okay, thank you. Good evening, everyone. My name is Katie Fauché, and I am an account executive with Accredo Specialty Pharmacy out of Louisiana. And I also have Mark Nelson joining me on another line. So it is an honor and a privilege for us to be with you this evening. As a representative of Accredo, I would like to thank Kathy for sponsoring this event and allowing Accredo to be a part of it. And also for Kristin, your talk was wonderful. Lots and lots of great points. It really was enjoyable to hear you talk. The level of engagement also from the IDF community have been very impressive through all the talks that we've been a part of. But then Accredo, what is and who is Accredo and what do we do? So Accredo is a best-in-class specialty pharmacy. We service patients with acute, chronic, and complex conditions, such as immunodeficiency. We're a leader in lots of limited and exclusive therapies. We also will go anywhere and to service anybody. We service in rural and urban areas. In terms of insurance, we have national coverage as well as accept Medicare and Medicaid plans. Accredo has a deep clinical focus in that we have an IG model that is definitely focused in our immune deficient patients. We have over 35 IG pharmacists on staff with Accredo, and they're spread out regionally to service you guys. We have over 600 nurses with Accredo, which most of them are employees of Accredo. These pharmacists and nurses are available to our patients 24/7. And I'll show you on the last slide how you can get in touch with one of those pharmacists or nurses. We carry most all IG and sub-Q therapies. Another thing, we also have patient advocates to assist you with any questions and to follow up with you, say 6 months, a year after you start therapy, or at any time after you start therapy, they're available to our patient. As you can see from this picture, we have field nurses, and this is some of the challenges that they have, been with during the pandemic. You can see that they're very well prepared in the suit of armor that they have. They take extra precautions. We have continued to see our patient in the home, but we also offer virtual education to our self-administration patients if that's what they prefer. Next slide. And this is how you can get in touch with anybody at Accredo. So 866-820-IVIG or 866-820-4844 or accredoivig.com/COVID-19. And again, thank you, Kathy, for letting us be a part of it, of the meeting tonight. It's very nice.
Thank you, Katie. And next, a word from our sponsor, Celio Health. I would like to have John May and April Landum join us.
I can go ahead and get started for April. My name is John May. I'm an account manager territory manager with Solio Health. And I'm also a registered nurse and a respiratory therapist. So I have some clinical experience over the past few years. A little bit about Solio is we are a national provider of specialty infusion therapies for deficiency and some other neurological deficiencies and diseases. We provide IG in the home, safely and conveniently administered. And then we also provide it in ambulatory infusion suites throughout the country. We have approximately 23 specialty infusion pharmacies now throughout the country, and we do provide service in all 50 states. 24 hours, 7 days a week availability to pharmacists and nurses that are specially trained in IVIG. And we have extensive nursing coverage from our nurses in the field that are employees of Solio. And when necessary, we do have contracted nursing in states and areas where we don't have employees. Nursing coverage, again, is throughout the United States, Hawaii, and Puerto Rico. And let's see here. We have what's called our Solio Connect program, and that is a patient prescriber portal that you've heard tonight a few times. So that's pretty much that. April, if you'd like, you can take over on the next slide.
Are you able to hear me?
Yep, we got you, April.
Okay, good. Okay, good. I'm sorry, I was started to talk a little bit. Yeah, so we also have a patient advocacy program where IG reimbursement specialists with expertise in insurance benefit verification and authorization. We have education on drug copay assistance and available foundation charity funds. So we help you go get with those foundations, so you make sure to get every funds that are out there to help you with your copay. Pharmacist support with letters of medical necessity. So the pharmacist will draft these and get these to your physicians if needed. Designated denial team focused on appealing for payer denials. So if you receive a denial for your medication, we will have a team that will help get those denials turned over for an approval. We have a facilitation of peer-to-peer review to advocate for authorization of coverage or to discuss denial of coverage. We also have patient advocates with firsthand experience as a patient or with a family member. We also have a travel program. So Solio has a network of Solio pharmacies serving all 50 states, allowing patient access to Solio care and services wherever they go. So say you travel and you're going to be somewhere in a different state for an extended period of time, we can service you even if you travel south for the winter. We have care coordination with Solio pharmacies, including nursing, to ensure a smooth transition of care from one location to another. Delivery of supplies and medication to any U.S. travel location. And instructions and assistance with securing medical records necessary for travel. And 24/7 Solio Health pharmacist and nurse on-call availability. So anytime that you need assistance or have any questions, you can give us a call. So that's really about it. If you guys have any questions, we would love to reach out.
Thank you. Thank you to both of you. Thank you, John. Thank you, April. And now we are going to switch over to the Q&A session. Thank you to so many of you that submitted questions before this evening. I think some of them were probably answered during Kristin's talk, and we will ask as many of those as possible. And also thank you for submitting questions during her presentation tonight, because we'll be asking those questions too. So here we go. First question. How do you approach or work with providers with inherent biases?
So the fact of the matter is that every provider you see has an inherent bias. So you're not going to avoid that. But that's where it comes to the question of second opinions, right? And I know not everybody is in a large metro area where you might have access to multiple opinions, right? But we all as humans have inherent bias. What you're saying, what I think what the question is really saying is, what do you do when your provider's bias is different from yours? And so the answer to that is, you have the right to seek another opinion. So that's where second opinions come in. I think sometimes, and I'm just going to be perfectly frank, and anybody who knows me knows I'm usually nothing but the fact of the matter is, patients who have a preconceived opinion when they go to their appointment are those that are often disappointed and unsatisfied. So what I probably should have mentioned as a part of being an effective communicator is we need to come at it with an open mind. So when I go into each appointment with my patients, I'm going in with an open mind. I'm going in because it's a new history on a new patient with new diagnostic findings. That's my open mind, right? And then we're asking the right questions, like, what's our medication options? Sub-Q IV, home care, outpatient infusion, self-administration, nurse administration, all of those questions have an answer. So if you're allowed to have a choice, right? Make your choice. But to say that, that you can avoid inherent bias is impossible. I think it's twofold though. I think you have to have an open mind, and your provider has to be willing to explain options. And if you're not happy with that, if you're not feeling like you're getting a full explanation of option and choices, then you need another opinion. You need another doctor.
What if a specialist, for example, a gastroenterologist in my area will not see you if you have been seen in another GI office in the past 5 years?
I don't know that is, I would report that to my insurance company, actually. Because if they are an in-network provider for your insurance company and they won't see you, that may be a violation of their contract with that insurance company. So I would go back to your insurance company customer service and say, I'm trying to get an appointment with Dr. M at mgi.com, but they won't see me. And I've been referred by my primary care, or I've been referred by my immunologist, and they still won't schedule my appointment. Can your insurance company help you? Because in my understanding, I know that within groups, and this happens all the time. So if you are trying to transfer from Dr. A to Dr. B, and they're both at mgastroenterology.com, they won't let you switch providers within one group. But I didn't know that was even an option, that they would refuse to see you from another local group. And if that's the case, and they're an in-network provider for your insurance, I would go to the payer and say, I'm gonna need some help here. Can you help me out? Because that sounds to me to be a violation of an insurance contract with the provider contract.
Is it ever okay for a healthcare provider to choose not to see you?
Yes.
If you've never seen them before, they're new, and they choose not to see you, is that okay?
Yes, that is my right. That is my right. This is based on who you've seen in the past, however. If I am turning away a patient I've never seen before, right? So a new referral comes in, I'm going to turn away a patient whose diagnostic findings, or who are being referred for something that is outside my scope of practice, right? So like I don't see allergy patients. So if somebody is being referred to me with chronic rhinitis and hives, I'm going to not see that patient. So that is my right as being able to define my own scope of practice, right? So that's one example of how you can turn a patient away. And my contracts with payers are for me to provide immunology care, not allergy care or dermatology care or rheumatology care for that matter. So the second way that I can say that I won't see a patient is if we have, let's say that I have had an established relationship with the patient and the patient violates this contract of communication with me. So maybe they've used abusive language. Maybe they have continually disrespected my staff, right? And they've been warned, or they've continued to no-show appointments with me, or they schedule and cancel same day, right? And they've been warned. I can essentially discharge a patient from my care because that relationship has been violated. And that is my right, just as it is your right to fire me if I disrespect your relationship with me.
In a situation when hospitalized, an RN fails to document correctly your medication, and then the doctor thinks the medication prescribed was not complied with, how do you approach handling this when they discharge you from your practice because of a misunderstanding? What can you do?
So I'm not sure I totally understand, because I don't know that this is all about hospitals. Is this about hospitalization?
It sounds like while hospitalized, the patient had information put into their records by an RN and it was incorrect. And then the doctor thought that the prescription, the medication was not taken appropriately by the patient. So now they're being discharged.
Oh,
So
well,
is there anything you can do there?
Yeah, absolutely. You can advocate for yourself there, right? And I think that you can get an audience with however you can communicate with that provider. So you may have to communicate in writing with that provider. And if you feel like you have to prove it, submit your pharmacy records and say, I've had this medication filled every month for the last 6 months. I'm taking it, right? It was an error, a hospital error. You could return to the hospital and say they have advocacy, patient advocates at the hospital level. And you could say, hey, my medical record is incorrect. I was taking this medication and it was charted incorrectly, or it was omitted from my record or whatever. Can you please make an addendum and send that to my, consulting physicians? So there are lots of ways around that, because your provider who is discharging you for noncompliance is making that determination off of bad data. So making sure that that data is corrected is your first option. But really, honestly, if it's me, I'm not discharging a patient based on that information without communicating with the patient. Because I'll tell you one thing I don't trust, and that's hospital records. So
when dealing with primary care or another specialist that does not understand the ins and outs of PI,
Yep.
What is the best way to get them to understand that they need to put in some extra effort to help me? For instance, they want to run a test, but I know from previous experience that my results will not be typical. So they read the test results inaccurately instead of expecting me to be not the typical patient.
So I feel like I take some responsibility in that communication, and that's why all of my visit notes are communicated to the primary care provider. So, you may have 17 specialists that consult in your care, but all I really care is that your primary care get this note, right? So I think me as a primary immunodeficiency treater, I have a responsibility to help primary care navigate those kinds of things. So you certainly can direct me to communicate with them, which I probably already am, or them to communicate with me, and take yourself out of the middle of that. I think that that's probably a uncomfortable place to be as a patient. But also the Immune Deficiency Foundation oftentimes can be a good place to direct your primary care provider for information. They have a tab that's specific for healthcare providers. And so one of the things, and I'm just going to use this as an example, that we have come up against in some school age children is that kids are with primary immunodeficiency disease don't always spike temps when they are very ill. And so we've devised a guide for nurses and for school nurses specifically that helps outline some of that. So the Immune Deficiency Foundation, and I don't need to sound like a commercial for IDF because obviously y'all know about it already, you don't need a commercial, but there are a lot of resources on that IDF webpage that are helpful for primary care providers. In fact, gosh, how long ago, Kathy, did we write that primary care article? The Nurse Advisory Committee, probably 9 years ago, we wrote an article about navigating primary immunodeficiency for primary care.
Yeah.
So I don't know, it's kind of a loaded question, and it's a long and sort of vague answer, but my office visit notes are half documentation of the patient state and half education.
How do we know if we're over communicating with our physicians? Sometimes I feel like I'm too detailed.
Right. Yes. And you might be. And that is where it comes back to communicating is a two-way street, and outlining the rules for communication are important. And so establishing those rules and then working within those guidelines that you and your provider set up is really important. You might be over communicating, right? And so you're not going to know it unless you ask. So when you're at your visit with your immunologist, you say, hey, listen, what do you want to know about, right? Like, if I go to my primary care doctor and he lances a boil on my butt, do you want me to tell you about that? Oh, no, you don't? Oh, what do you want me to tell you about? Oh, an ER trip with a chest x-ray that was positive for pneumonia? Got it. Right? So those are the kinds of things that you and your provider need to outline. You liked boil on the butt, didn't you, Kathy?
I did. I was entertained by that. Thank you. Loved it. I was diagnosed with CVID 2 years ago. How reasonable is it to discuss having genetic testing for my daughter's knowledge? My mother had lung issues for the last 20 years of her life and finally died from non-Hodgkin's lymphoma.
Suspicious, right? Genetics are becoming a day-to-day expectation from immunology. So genetics are getting cheaper to run. Now, asking the question, when do I bring up genetics for my daughter? We wouldn't screen your daughter. So unless your daughter is symptomatic, we would not screen your daughter. But you, as having a CVID diagnosis, could very well fit into an Invitae screen or some sort of a chip diagnosis, looking at some of the almost 400 known genetic defects that we know for CVID. So CVID, as you all probably already know, is not one disease, right? There are hundreds of gene mutations associated with the phenotype of CVID. And phenotype is just the expression. The expression of CVID is the result of many hundreds of genetic disorders. And so if you have a CVID diagnosis, should you be offered genetic screening or genetic inquiry? Yes, I agree. I think that you should. If you are in a small town or in a practice where an immunologist that's caring for you maybe only has a handful of CVID patients, that immunologist may not know where to go for genetic testing. And that would be a shout out to our medical advisory board of the IDF. So there is a consultant who is available to help your local immunologist find ways to get genetic testing done.
You mentioned that you share medical information with PCPs. So if I have more doctors in managing my care, how do I get all of them to communicate with each other?
Oh, that's the $1 million question. You don't, right? The fact of the matter is HIPAA has made it difficult for us to intercommunicate from specialty. That's why the primary care role is of the utmost importance. So your primary care is the hub of the wheel, and communication needs to go through your primary care. Now, there are distinct things that I need to get from other specialists. Like I frequently request records from pulmonology because pulmonology did your lung functions. They maybe did a CT scan of your chest and are helping with some of the surveillance. That is a metric of my success, right? Like if your lungs are good, I'm doing a good job, right? Because that's my main goal, is I want to protect your lungs. So your pulmonologist and I oftentimes will swap information one-on-one. But HIPAA has made it real tough for us to get information smoothly back and forth. I think that that's a really valid question to talk to your immunologist about as well. So for instance, you are a CVID patient with a good primary care. You see gastroenterology because you have chronic diarrhea or colitis. You see pulmonology because you maybe have pulmonary nodules and some asthma-like symptoms. And you see dermatology, who takes care of your atopic dermatitis, your eczema. All right. So of those four specialists, I'm going to put myself in there, immunology. So of those four specialists, who should be communicating with whom, right? So I will very often send my consultations to pulmonology, and that is sort of my plea to get information back from them, right? So if I send to them, maybe they'll think about sending information to me, and I don't have to do a medical records request each time. But you can also be a pilot of that. So when you come to my clinic, you can say, hey, I need you to communicate with Dr. Smith in pulmonology, Dr. Evan in ENT, and Dr. Leach in dermatology. You know what? I'll do it. It's just a push of a button for me. Can you do the same for them though? Can you make sure that pulmonology is sending their notes to immunology? Once you've established that ability to communicate that between, and I'm not talking about just immunology communication, but you can communicate with your pulmonologist and say, hey, my immunologist really needs this information. Can you put her on the CC list? Chances are they are going to, because they know that it decreases the calls to their office and the burden on their medical records.
I have been receiving a specific product for my IVIG. I was told at my last infusion that I was going to get a different product. Mm-hmm. Is this a local infusion center decision, an insurance or Medicare decision? And is there even a reason I need to be an advocate for one product over the other for myself?
Good question. That is a great question. The landscape of this is changing all the time. And part of the reason it's changing is because of supply issues. So there's a lot of reasons why products might be changed. So all of the reasons you had, like, is this a infusion center specific issue? Maybe. Is it an insurance company issue? Maybe. Bless you, Kathy. Is this, there are lots of reasons. Maybe your outpatient infusion center doesn't have a predictable supply chain of your product you were receiving, and they got a guarantee from a different manufacturer, like, oh, we can get you enough grams to service all of your patients. This is a very up and coming problem right now. One of the biggest battles, I told you, I spend about 25% of my time fighting insurance companies each week. One of the biggest things I have fought recently is formulary choices. So your insurance companies are now contracting with manufacturers to put their IG products higher on the formulary, so that if I want to put you on a sub-Q IG product, I have to put you on their preferred formulary option rather than the one I want to choose. So there are so many reasons why a infusion center, home infusion pharmacy, or a hospital even would change your product. Is it bad? Well, right now I'm going to tell you no, because the products we have on the market are all so very comparable when it comes to safety, efficacy, viral activity, screening. The big variables are, what's the availability in your area, right? Can your provider, your pharmacy, can they get the product predictably? That's probably the biggest variable in all of this. But for the most part, the products that are on the market right now are all so safe that they're not interchangeable based on your tolerability necessarily, but they are interchangeable based on safety and efficacy. Now, let's speak to tolerability for a second. Sorry, my dogs are fighting. Wrestling is fighting is a bad word, but tolerability. So whenever I have a patient switch from one brand to a brand they've never had before, I ask the infusion center or the home infusion organization to consider it a first infusion. So let's say you were getting product A in 2 hours IV. If they have to switch you to product C, I'm going to ask them to go to first dose protocol, which may move you back to a 4-hour infusion. And then you have to work your way back up to that 2-hour infusion rate. And that's just for safety. Is just because you tolerated product A perfectly doesn't mean you're going to tolerate product C perfectly. And if you don't tolerate it, then it's probably a reason to try and authorize the preferred product. And that is a battle that you got to glove up for.
This will be the last question. I asked my diagnosing doctor if my T cell and B cell function was something that should be looked at. Her response was that it is something, if it is something you want to be looked at, I will have to refer you to somewhere else. Is looking at these things necessary for treatment?
Okay. There are so many ways to talk about this question. So T cells are lymphocytes that are the generals that send signals to all of your immune cells, okay? T cells can be looked at in 2 ways. They can be looked at in number. So do you have the right numbers of T cells? And they can be looked at in function, okay? B cells are another type of lymphocyte, and the B cells are the receiver of signals, and they are the factories that produce antibody. They become the factories that produce antibody, okay? So if your T cells don't work correctly in signaling, your B cells don't work well in producing. But in antibody deficiency, we can make a diagnosis without knowing any part of that, simply by looking at the end output, which is antibody. So the diagnosis of CVID can be made based on the amount of antibody that you produce or don't produce, and the quality of that antibody. So for instance, I can just look at the numbers game and tell you if you have CVID based on your IgG, IgA, and IgM levels, right? So that is sort of the rudimentary diagnosing guidelines. I always look at T and B cells, but this is all I do, right? Like I just do primary immunology, and I have at my disposal a lab that will run all of those tests for me. So at a minimum, if a patient is diagnosed with CVID or antibody deficiency, I will look at T cell numbers and B cell numbers, just to make sure that all of the soldiers are accounted for, right? So if your hometown immunologist does not have the ability to look at T and B cell numbers, it still doesn't change the fact that the end output is low. You still have antibody deficiency that's consistent with CVID, and your therapy is prescribed as IVIG, which is the right therapy. So do T cell and B cell numbers affect your therapy? No. Do they affect prognosis? Maybe. Maybe they do. Does that make sense? Was that enough of an answer, Kathy?
Yes, that was wonderful. Kristin, you are amazing. And actually, one of our attendees tonight in the chat said, this presenter is great. So down to earth and knowledgeable. Thank you. And I could not agree more. So at this time, we are going to say thank you. Thank you for volunteering your time, Chris. Wonderful presentation. And thank you everybody for submitting questions. If your question wasn't answered and it was submitted prior to this evening, we will follow up with you with an email. Or if your question was submitted tonight via the chat and your name is attached to it, we can follow up via email. If you have additional questions, as long as they're not totally specific about your health, please submit them to Ask IDF through our website. So once again, thank you, Chris. Amazing presentation. Thank you, everybody, for submitting such great questions. And thank you to our sponsors for making this event possible. So at this time, thank you, everybody. Thank you for joining us tonight. We hope you found the information helpful. And please remember that IDF is here for you every step of the way on this journey. And we look forward to seeing you next time, 2 weeks from now. So take care, stay safe, and have a great evening. Bye.